I know you all have had a long day. I'm just going to, I'll try to be as brief with this presentation given the little time that we have. Uh, you all know that Arvind's vision is to mainly eliminate needless blindness through so-called compassionate eye care, making this eye care affordable, basically reaching out to more patients, of course training of ophthalmologists and building capacity among other associated organizations. Over a period of time, we have seen that cataract intervention effectiveness, there are many ways. It was in one of the studies, we found out that in a community, if we did not interfere or do any active intervention, the acceptance of surgery, people coming by themselves was around only 15%, whereas when we did eye camps or the various other house-to-house visits and other things, the effectiveness was much, much higher. And eye camps being the most easy to approach was done. Today we conduct regular eye camps, 20 to 25 screening camps per week across all our Aravind Eye hospitals with the participation from the community, wherein the community takes ownership for organizing the camp, and we do the screening and bringing the patients to the hospital and then taking them back after surgery. So this has been fairly successful and very effective. As I said, we call this as comprehensive eye care in the community, wherein we screen for not only cataract, but all ocular diseases, mostly glaucoma and any other retinal pathologies or corneal ulcers. Today we are able to deliver spectacles on the spot and bring patients for cataract surgery and referrals for specialty services. We also follow up these patients in the same campsite after a month. So in the last 1 year, between 2011 and 12, we have had almost 1,358 comprehensive screening camps, where the average number of camps have been 30, and the average number of patients brought for surgery was around close to 2,000. So besides this, what did we do? We were doing the screening camps, and then we realized over a period of time that we need to look at other specialties such as diabetic retinopathy, glaucoma, and pediatric screening camps. So we started working on these, and basically we started doing school screening camps, wherein our team would go in and screen in the schools for vision problems among children. This is one of the eye camps where the teachers are trained to identify children with low vision. They are taught to identify or do the vision screening for these children. And these children which are identified to have low vision would be then screened by the paramedical team that goes from Aravind to prescribe glasses or find out if they have other problems or whatsoever. And then the doctor examines these patients and prescribe them glasses or refer them to the hospital in case they have other issues. Then subsequently we decided over a period, what we call as workplace camps, wherein our team would go into industries or institutions, do a refraction for many of those workers there, give them glasses and prescribe them glasses. And this here, it was very much acceptable by the team, by the patients when they were shown that they could do much better with these glasses. How did this happen? Long back, we did a study in a textile industry where about 240 workers representing spinners and winders were studied. Their baseline productivity was recorded. Spectacles were provided to all those who needed, and they were followed up. And then again, the productivity was measured subsequently. In this, 71% of the workers were 40 years or older. 79% required spectacles, and of these, only 4% were wearing appropriate spectacles. 4% were having incorrect spectacles, and 92% have never worn spectacles. So over that study, the employers reported a higher overall productivity of almost about 10%, and even subjectively the workers showed a lot of improvement or satisfaction. And this became a norm for many of the industries or institutions wanting to do this kind of eye camps in their workplaces, so they started inviting us to do that. This is just to give you a number of camps that were conducted in the workplace, about almost 195, wherein we had screened about close to 50,000. And it was surprising to see almost 85% acceptance rate of glasses among this group who have never worn glasses previously. So you can see the large need that is lying out there. This is again our team. There are mobile refraction camps that are being conducted with just the refractionists or optometrists going into the community in a mobile van and doing on-the-spot screening camps for refraction. And again, we found a large number of acceptance among this group. Coming to this major problem, which is with India as the diabetic capital, all of us are aware of this major problem with its associated complication of diabetic retinopathy. What it means for our country, this is a 2005 data. If you look at based on the experience of about 30% of the 38% of the population above the age of 30 years. We looked at it, and among this, if you assume basic 10% of them would have diabetes, which is about close to almost 420 lakh, 42 crores, or yeah. And among this, the DR population, if we estimate it to be around 11%, again, it's about 46 lakhs of these patients. And if you, and among those, if you see, we presume almost 20% will need some treatment such as laser or surgery, which is close to 10 lakhs in number. This is a huge number out there, but we are hardly touching this number with the low number of retina specialists who are doing this work. So as an initiative at Aravind, way back in 2000, we joined hands with Lions International to start this diabetic retinopathy project, and subsequently we did this with the World Diabetes Foundation and TIFACOR, which is the Government of India's initiative. We have been doing public awareness campaign on diabetes and diabetic retinopathy, conducting press meetings, seminars for doctors, patient interaction meetings, diabetic exhibitions wherever possible, giving books and mass mailing about diabetes. And we would develop such books for general public on the World Diabetes Day. We would put up these stickers on all the public transports, auto rickshaws, wherever possible, displayed at the various physicians, hospitals and clinics on the importance of eye screening for diabetic patients. Subsequent, and from day one, we have been organizing eye screening camps specifically for diabetic patients in association with diabetologists or physician. We would go to one of the smaller towns where we identify one physician who would join hands with us. They would screen the public for diabetes, and once those who are identified diabetes would be screened by our team for diabetic retinopathy. Otherwise, it was impossible for just us going and screening the common general population for diabetes. This was a win-win situation for both. For them, they were getting, the diabetologists were getting new patients, or the physician were getting new patients, and we were getting our target population, so it worked very well for us. This is for the last year, the number of camps close to 200, and we have, the major problem is in bringing these patients for treatment, because unlike cataract surgery, which is a one-time intervention, here these patients have to be seen multiple times, and it's an ongoing thing. So it is easy for us to go do the laser at the site and come back. But that doesn't stop there. We need to have a continuity of care for these patients. So this way, by bringing them or referring them to the base hospital, we show them the way to come on a continuous, as a continuous process. So what did it mean to us for our, the base hospital over a period of time since we started these kind of campaigning, talking wherever possible we would go, wherever people are doing sedentary work, like in the banks, insurance companies, wherever those offices we would go, talk about diabetes and diabetic retinopathy. Our team will go on one day and then do this. So this kind of campaigning has brought in our volume of patients in the retina clinic. The number of diabetics have grown tremendously. What we also saw over a period of time, when we were seeing 100 patients in the retina clinic, there was only 30% of them were diabetic way back in 2000. In 2006, we showed out of the 100 patients, though the absolute numbers had increased, out of 100, we had almost 67% of them were diabetes-related patients. So that means the awareness had tremendously increased among these people. And we also do what we call as opportunistic screening. We have been doing this tele-screening, which Mr. Tulsiraj had shown you in the morning with the mobile vans. With the same experience, we went in and put fundus cameras in the diabetologist's office or the physician's office, trained one of their technicians to take fundus photos, asked them to send over the internet through these images to the base hospital at Madurai, where there is a reading center. One of the retina specialists or a trained grader would look at these images. They generate a report based on what he is seeing, whether the patient needs treatment or no treatment, and the report is sent back. And this whole process takes place within 1 hour. So it's like a patient having a blood test done in the diabetologist's office. He goes for the fundus image. By the time he finishes all the investigations, his eye report is also there. By the time he goes to see the diabetologist can tell him, yes, you have an eye problem, go see an ophthalmologist. So this way we are able to, this we do every day. I'm sure those of you who visited the retina clinic would have seen this. And this is just a video of the same process. This is actually one clinic situated not very far off from Madurai, far off from this hospital. But, these patients, they still are screened. The reason why, as most of you ophthalmologists know, the diabetic patients or the diabetic retinopathy patients do not have any problem. They have a normal vision in the early stages of diabetic retinopathy, and so they do not bother to come to the hospital or to see an ophthalmologist. But they will definitely be seeing their physician. So this way we said we will go pick it from where they are coming. We also used to educate these lab workers, the medical pharmacy people. We brought them here, showed them what is diabetic retinopathy, and we told them that the importance of when a patient comes to you to buy diabetic medicine, tell them that they need eye screening. So these are all the things that we motivated these patients. So that way the numbers started increasing. This is to show the number of patients that were done through tele-screening in the last 2 years. If you look at it, the new DR, almost 72%, these are the people who have only some diabetic retinopathy changes, but they don't have any vision-threatening problem. So these patients would never go to the ophthalmologist unless otherwise they are shown by the fundus photos that they have problems. So this way we are able to move the patients early on to the diabetic retinopathy or a retina specialist. Glaucoma screening is again very, very important. We screen all those patients who are 40 and above coming to the hospital. We do rescreening of those who are brought to the hospital for cataract surgery. We do family screening because 18 to 20% of the screened family members have had glaucoma. We regularly conduct awareness meetings every week or once a week or Tuesdays in the afternoon. We conduct awareness meetings for all the people who are out there in the clinic. We tell them there is an awareness meeting going on. So everybody goes there to understand what is glaucoma. Over a period of time, we realized that, there are a lot of people doing cataract surgery, cataract intervention, and we realized that it's a time we moved to other areas which need care. such as diabetic retinopathy or pediatric ophthalmology, glaucoma. So even just to motivate people, 3 years back we trained that year as year of specialty, meaning that we focus on specialty, not only on cataract. Cataract will be an ongoing project, but we started putting intensive efforts on other specialties like glaucoma or retina. So in designing outreach models, you can see that we have screening for all ages starting from 0 to 5, where we conduct pediatric eye camps, 6 to 15 school screening camps, 16 to 49 we do a workplace screening camps, 50 and above we have other things such as cataract, diabetic retinopathy, glaucoma, etc. This we didn't do alone. We have been doing it always by engaging the community very actively. This has been our day one success. From the time Aravind Eye Hospital was initiated, we have been working with the community because we make sure that the community owns this. So this way, until today, it has been a partnership that has been working very well with various organizations that you see here. And there's a very, very structured monitoring process. Every week, these camps are analyzed. How many were done? What is the performance? How many cases came? What is it lacking? What are the areas that are not covered? And this way, it has been very, very helpful. And this is very, very intense. Every Monday, this happens. And not only this, way back, I remember when I started with Dr. Venkatsamy, we used to go to the camp. If the patients did not come for the camp, he would tell each one of us to take a torch, go walk door to door and start screening for patients. So this was his motto. When patients didn't come to you, you go to them and bring them to you. Show them the way that there is something that can be done for these patients. In one of the studies in the late 90s, it was found that in spite of all these efforts, only 7% of the people with eye problem in a village were accessing eye camps. So that thought made us think further on what do we do for these people, and that's when these vision centers came up, which you have been hearing about, you have been seeing. So I will not touch upon this too much. So we have each base hospital at Aravind is connected to multiple vision centers. Like Madurai is connected to about 12 vision centers. There are each hospital has about 5, 6, depending on the area it caters to. And as I said, currently there are about 40 vision centers catering to 2.6 million population in 13 districts of Tamil Nadu. We have screened more than 5 lakh patients. And today, an average OPD load per day across all these vision centers about 720. What was seen is that over the years, from the time it started, if you see the number of vision centers during which it has existed, the coverage increases. Like if it had been there for more than 4 years, it almost covers 89% of the population in that area, which means it is taking care of 89% of the population. It has seen in that particular district it caters to. What is the quality assurance? We have these electronic medical records and teleconsultation. There's a monthly visit by a team of ophthalmologists. Each doctor is given a few set of vision centers which they have to monitor and go every month to visit and see the how it functions. Performance review based qualitative and quantitative parameters every 6 months, database monitoring to improve efficiency in service, and we also make sure that we follow up on those patients referred from the vision centers to this place, and cost control through financial reviews. So outreach is definitely a proactive strategy which Aravind has been using from day one when it was started. Even as an 11-bedded hospital, they used to go out into the community to screen for patients. It helps to reach the community, creates demand for eye care, and helps to reduce the backlog and achieve the optimum vision that it is seeking. The other side of the outreach and training, especially in institutions like ours, it is necessary for the training of residents, not only just for bringing patients. It brings in a different process for the residents, For the residents who are going into the community, it gives a better understanding of the community. They become sensitive to the community issues when they are there in the field, and it also helps on training them to make quick decisions or on-the-spot decisions when they see patients with problems. So in this, through all these processes, these are things that we have been developing, and what has been helpful as we see back is every time we hit upon a problem or a challenge, we always take it as a challenge and try to innovate and make sure how to use this to build the vision or bring in patient care or increase patient care has been the way we have been working till today. And I think that is one of the ways we have been able to succeed in these processes. Thank you.